carry on with the session. In the next 20 minutes or so, we'll be talking about drug de-escalation in practice. So even though it's a fag end of the day and it's the last topic, we'll be moving towards the high T and the validatory function after the session. It's a quite important topic, to be honest, because our patients have n number of conditions. Every condition has one pillar, two pillar, three pillars, fourth pillar, and now fifth pillar also. So if you add all pillars to all of our patients, patient will be ending up with bunch of medications, and it's a great conundrum for the physician and the patient as well. One more situation where almost all of us find is that there is an inertia to initiate insulin from the patient's perspective and the doctor's perspective. How much ever we talk, listen, read, study, practice, whatever it be, our patients are never willing to start insulin. So finally we end up giving 3, 4, 5 medications, oral medications to our patients. So with that at outset, let's start with a case study. So he is Mr. R, 78-year-old gentleman with 22 years of type 2 diabetes. He lives alone. Every point is important. He lives alone. He's a widower, independent in basic activities of daily living, needs help with shopping and finances. Recent falls 2 to 3 in a month. Post-meal giddiness is there. 3 self-treated hypoglycemic episodes, and last month there was an episode of severe hypoglycemia. Comorbidities: CKD stage 3B, EGFR of 38. Then prior NSTEMI 5 years ago, heart failure with preserved ejection fraction, NIHA class 2. Hypertension, dyslipidemia, painful diabetic peripheral neuropathy, BPH, GERD. He has all the conditions in the world. Cognition rating 23 out of 30. What matters most? He want no more disease spells or falls and fewer injections. So vitals: BMI is 24. BP, blood pressure is 124/66, and there is an orthostatic hypotension. Heart rate is 78. Pedal edema is there. Monofilament test, its sensation is almost absent. So key labs: HbA1c is somewhere around normal range. Fasting SMBG is somewhere around 80 to 120. LDL is 58. Potassium is normal. Hemoglobin is 11.8. Creatinine is 1.6. ALT is 22. Vitamin B12 results are pending. So let's start discussion. So I would like to ask Dr. Aniket to comment upon this patient. What are the red flags you see in this case?
Yeah, it's a really interesting case. He, a 78-year-old gentleman, has all the anti-diabetes medicines that we know. So he is on sulfonylureas, he is on pioglitazone, he is on insulin, he is on sitagliptin. He is on GLP-1 receptor agonist, and he is a known case of more than 18 total 18 medicines he is getting. So most of all the OHAs are there along with insulin. Then for his hypertension and prior NSTEMI, so he has that lisinopril 10 mg, amlodipine, furosemide is there, aspirin along with rosuvastatin for atherosclerotic cardiovascular disease. And for BPH, he has the tamsulosin. He takes omeprazole for the whole sorts of GERD or dyspepsia he might be getting because of all these medications. He takes diclofenac for his osteoarthritis, gabapentin for his diabetic peripheral neuropathy, that too in 300 mg TID dose. Zolpidem for insomnia and clonazepam SOS. So you see, this is a classical case of polypharmacy. So when a patient has more than 5 medicines about the age of 60 years, so we label him as a case of polypharmacy. And if we just go into the details that how each doctor might have had each single medicine. So in India, we have a healthcare system fragmentation. So neurologist looks at a patient differently. So he adds gabapentin for his peripheral neuropathy, but he sometimes doesn't look at what stage of CKD he might be having. So we need to have that comprehensive holistic care, and we have to stop certain medicines because he is suffering from a lot of side effects of these medicines. So red flags are too much of OHAs are there. So we need to stop sulfonylureas here. then we have to just knock off that pioglitazone because he already there is a component of heart failure is preserved ejection fraction, but he is a known case of heart failure. Then we have to come down on dose of amlodipine because orthostatic hypotension is there, along with because tamsulosin being alpha blocker again causes orthostatic hypotension. And then we have to cut down this, just stop the diclofenac because he's just CKD stage 3. Gabapentin we have to cut down on dose because he is having the side effects of gabapentin because already he had two to three falls in last 3 weeks. So there are red flags and we need to stop certain medications today itself.
Yes, sir. Yeah, rightly mentioned. So I think my next question will be to Mr. Dr. Janish Vira. So usually we end up with such patients, but there are certain criteria when to refer to a specialist. Like early nephropathy, we are supposed to treat. Early diabetic neuropathy, we can treat. But the problem with referring to a specialist is that they tend to add on medications. So for simple example, patient is having a frozen shoulder. If we try to bring the HbA1c down, we can, with physiotherapy also it will come down. But if we send to an orthopedician or any other specialist, they tend to add on 3 to 4 other medications as well. So what are your views on referral to a specialist in such patients?
Basically I don't mind referrals unless and until there are grave problems. But for small things like frozen shoulder, of course it can be managed by physiotherapy as well. Like for this patient, he is a 78-year-old guy. So basically whatever comfort we can give him, because now for him it's living at peace. We are not seeing to give him next 20-25 years of life, that we be so strict with his HbA1c levels, or we are back like in this slide we can see patient is on GLP-1 as well as DPP-4. So we need to knock off those drugs, bring to a level where he is happy now living the life basically.
Yeah, rightly said. So next, I think Dr. Daman, you want to add something like, see, for example, we have n number of red flags for this patient, like sliding scale insulin is being followed, sulfonylurea, he's getting severe hypoglycemic episodes, long-term PPI. That is one area we want to mention. Once we prescribe a PPI, patient tend to continue it for lifetime. So as doctors, we never tend to stop it. So what is the ideal time you prescribe PPIs, and like how do you see the overusage of PPIs in clinical practice? Because many a times again cross specialization, we will be prescribing rabiprazole, the other person will be prescribing pantoprazole. So patient will be taking 2 to 3 PPIs also together. So how do you see the long-term use of PPIs in clinical practice?
Patient is already on PPI.
Yeah.
Patient already on PPI or doesn't have any symptoms of any dyspepsia, it can be gradually tapered off. If already taken for 6 to 8 weeks, we can gradually taper off, because long-standing use of any PPI is going to cause hypocalcemia, hypomagnesemia, even B12 deficiency. So yes, we will take care of all these things into account. Gradually withdraw PPI inhibitors. I think sliding scale is now no more existing.
Absolutely.
Okay, we need to just do a good SMBG for 3-4 days, and depending upon we can adjust the insulin dose. In this case, the giddiness fall may be because of the hypoglycemia or a postural hypertension. So as he said, we need to de-escalate the dose by 10 to 20% of the insulin, and patient already was on glimepiride. We need to switch to a shorter acting sulfonylureas, or we can gradually withdraw the sulfonylureas also. And I think these 3 things we need to do it. And it was also, I think, on tamsulosin, right? Yeah. So in each patient there can be switched to sildosin, preferably, which is got a lower postural hypertension. So these things we can do for de-escalation in terms of dizziness and.
Yeah, thank you, sir. So, Dr. Kirti ma'am, my next question will be, see, when any patient coming to us with diabetic peripheral neuropathy, we will be given either pregabalin or gabapentin. But when it comes to an elderly with reduced EGFR, first of all, with recurrent falls, whether to initiate, and if you are starting any of such agents, how long will you give and when to stop such molecules? What is your personal take on that?
Talking about the peripheral neuropathy?
Yes, ma'am. Painful peripheral neuropathy.
Let's go to the first slide first.
Yes.
We missed a lot of things over there.
Yeah, sure.
So basically we are talking about de-escalation, and what we said was take every word into account. Relax the targets, relax everything.
Yeah.
Relax, adjust the dosage, rationalize the drugs. We need to work on that. One thing, retinopathy is missing over here. Must be sure he will be suffering with it also.
Yeah.
So,
I think high index of suspicion is necessary.
see, CKD is there, CKD is there, hypos are there, we missed it. Now coming to the next one. Peripheral neuropathy, though, after 20 years,
Yeah.
gabapentin already we are giving 300 tries. Recurrent falls and spells are there. We are talking about escalation, escalation and escalation. Now, it is the time to de-escalate. We have to de-escalate in every aspect, relaxing the targets, reducing the number of pills, reducing the medication. And definitely symptomatic relief is must. Need not always go for ye drug nahi, then add the anti, add tryptomer, change gabapentin to pregabalin, no. Relax everything. Consider other differential diagnosis also. We are talking about painful neuropathy. Need to look little for the spine also. Maybe something is there. So this is my take.
Yes,
on it.
ma'am.
We have to
Talking
be very
about-
rational.
Talking about relaxing the targets, I think Vimohan sir used to tell us, like when the patient is above 70, 75, the HbA1c target, put a dot in between the age. So if the patient is 80, HbA1c of 8 is also fine. So for this patient, we need not keep him at 6.4. So let's talk about a proposed de-prescribing plan. We had planned it through various stages. Say for example, stage 0. Again, a retarget of A1C to around 7.5 to 8 because he is elderly, multiple comorbidities, risk of falls. Prioritize no hypos as ma'am rightly mentioned. So it will reduce his falls and we can go for fewer injections. Consider CGM, continuous glucose monitoring for safety during the changes. So stage 1, we can again high risk removals and simplification of the drug regimen. We can stop the sliding scale. First of all, it's obsolete these days. We don't give at all. We can try stopping glimepiride because insulin with the sulfonylureas usually in an elderly is a red flag. It's a big red flag. So again, sitagliptin is given along with the GLP-1 RA. That is also very, it's not practiced at all. Stopping pioglitazone can be considered because again, he has heart failure. Then reduce metformin dosage, EGFR is low. Semaglutide can be continued. Then empagliflozin, maybe we can up titrate also. Empagliflozin 10 and 25 we can still think about it. Basal insulin, again cut glargine from 20 to 12 units. All these things we can do with the help of a CGM. It's not that these are hard and fast rules. We can take it on a patient to patient basis and on a day to day basis if required. So stage 2 will be adjust to data. If fasting is less than 90, we can still relax. We need not be less than 90. It has to be somewhere around 120ish or 130ish for this patient. A1C projection should be around 8. And if postprandial excursion is symptomatic, you can up titrate the GLP-1 RA rather than adding a bolus insulin in this patient. Stage 3, talking about falls and everything. Taper and stop clonazepam and zolpidem. Over 4 to 6 weeks, it has to be slow. Maybe we can add a low dose of melatonin. Reassess the addition of tamsulosin. We can give a silodosin rightly mentioned by one of our speakers and step down or stop the PPA unnecessarily. We can stop diclofenac because the EGFR is low, creatinine is 1.6. Gabapentin 300 milligram thrice daily has to be reassessed and maybe we can consider it as once nightly formulation of 100 to 300. And monitor for sedation or falls. So the medication map, what to keep, switch or stop first. Keep monitoring. Switch to basal insulin to lower dose. Consider pen equivalent for to reduce errors. Most of the time with insulin, when an elderly patient himself is taking, that is the first thing we have to consider. There will be reduced vision. They may not be well equipped with the insulin devices, pens and formulations. And I think rightly mentioned by the previous speaker also, most of the time 100 IU insulin will be taken in 40 IU syringes and the other way around also. So stop the culprits: SSI, sulfonylurea, thiazolidinediones, DPP4, benzodiazepines, chronic PPI, and NSAIDs. And monitoring and follow-up, we can get help of a CGM and or structured SMBG, and check BMP 1 to 2 weeks after any ACI, a diuretic or SGLT2 adjustments. Recheck A1C in 3 months. Accept a lower or better higher HbA1c rather, and food checks every visit for neuropathy and falls. Evidence pearls: de-intensify when harms exceed benefits. ADA explicitly supports raising A1C targets and simplifying regimens in older adults. Avoid sliding scale insulin and avoid sulfonylureas in older patients when alternatives exist. In type 2 diabetes with CKD with albuminuria, SGLT2 plus or minus finerenone on top should reduce renal events. And start V3 and give concrete targets for prescribing the benzodiazepines. Avoid DPP4 with GLP-1 RI combination, has very little incremental benefits. I think that will be the end of my presentation. I think we'll carry on with the valedictory function, followed by the high tea. Manoj sir is eagerly waiting.
Asking whether it is a panel discussion or
No, feedbacks were taken. Yes, sir. Yes, sir. Yeah.
These are the classical case we see normally in elderly patients. It was rightly pointed, all the drugs, what we need to discuss. And one of the good topic, we always try to escalate, do all the things. Not to do is also equally important. And that we miss many times.
And
very good topic.
Yeah, the most important thing is the two criteria are there: when to de-escalate and how to de-escalate. One is the BS criteria, which has been again updated in 2023. It is again by the American Geriatric Society. So that specifically mentions that how to de-escalate the drugs and identify the major culprit, that what is causing like hypoglycemias, falls, and severe risk to the patient. And then there is another criteria, stop and start criteria, that is again by the American Society. So where they have clearly mentioned that sometimes, most of the time what we do, that we do see anticholinergic side effects with the simple prescribed medicines like diphenhydramine or simple anti-cold medications can have and severe side effects in elderly patients, that too anticholinergic like side effects, and that again worsens the tendency of these elderly patients, especially our patient was a single, he is alone, he lives alone. So it is very difficult to even recognize that these patients fall, they have such kind of severe hypoglycemia, they may sometimes have a coma also, hypoglycemic coma, and nobody recognizes it. So it's a severe issue, so we need to de-escalate as per the criteria. We have to identify the culprits first and so relax all the norms.
Because I was also of the same point. Already 78 years. BMI has come to 24. He has CKD. And now there is also no point in keeping a SEMA of 0.5 going on. You can stop that, give him a linagliptin or something which is safe in CKD. Because with SEMA, again, he will have GI side effects. So pantoprazole lete rahega. So basically, after certain times, my funda is jeene do usko. After 78, if you try more, then he becomes Trump. And then de-escalates everything.
Yes.
If the patient is active, able to manage his or her own daily routine, it's okay. Be tight with the targets. But if a patient is like this, typical case, what we see in our houses also, our elderlies, great dadis, nanis, they are like this only. Be little relaxed. I do tell my patients, meetha bhi kha lo. What will happen? And relax everything.
A lot of times the patients themselves tell us, I am going to eat this, no matter what you say.
Yeah.
Their diet is already very less.
Yeah.
Yes.
Most of the patients tends to come and tell us, I have lived like this for past 40 years. Now.
And you know what? They have lived with diabetes far longer than what we might have practiced.
Yes, ma'am.
So they always end up teaching us much more.
So
But
actually,
that-
Purvi, I'm talking something very informal. We had a discussion ki maybe we'll not have any single listener over here. We all four will be. But thank you everybody.
But here again, interesting scenario in India. Typically, where I practice from rural India, तो नेफ्रोलॉजिस्ट अलग मेडिसिन दे देता है, न्यूरोलॉजिस्ट अलग दे देता है. न्यूरोलॉजिस्ट अगर देखता भी नहीं कि नेफ्रोलॉजिस्ट ने क्या मेडिसिन दी है उसको, व्हाट मेडिसिन, तो पेशेंट पूछता है कि पहले मेडिसिन में चालू रखूं, हाँ चालू रखो, उसमें मेरे 3-4 मेडिसिन और ऐड कर दे. So nobody wants to de-escalate. Everybody wants to escalate the drugs as the age goes up. So this de-escalation should be there as a comprehensive care, and where here the role of EMRs and all the integrated healthcare system comes into the play.
Actually, we just had framed the case, but de-escalation can be in various situations.
Exactly.
So, Dr. Kamlesh Kundi from the UK, he and that entire group, they are at Leicester, they are doing amazing work. I mean, they have a lot of good publications in de-escalation of therapy. So I think it might just be a good thing if we get something from India also. Think about it very seriously. But let's get a nice, good quality publication out. So that's something more meaningful in the Indian context. I think that will,
Yeah.
because this is something that we don't always see. Everybody's treat aggressively, start early, combination, ye add karo, wo add karo. I think it's the time is right that we also talk about, because longevity has increased, we are dealing with that population, and they also themselves have not thought about what is going to happen to them post 80 or post
Most of the
middle-aged.
patients tend to take multiple multivitamins,
And
omega 3.
so many times we have, no, that is happening now in urban India in the perimenopausal population. Yes, supplementation is great, but this is over supplementation. I don't know what all they are taking. And there's great marketing also. So they, ye bhi lo, wo bhi lo, as if that's going to, make up for lack of lifestyle changes themselves. So that's one thing, but I think again, a lot of times hypoglycemia can be mistaken as depression. And so I think that's another pointer that we start looking at, if you find somebody depressed, then look for hypoglycemia, because the reason may be just hypoglycemia and not real.
And sleep disturbance also, many a times it's nocturnal hypoglycememia.
Sometimes even hypoglycemia, patient presents at dyspepsia. Sir, शाम को 5 बजे जलन होती है, मुझे एसिडिटी होती है 5 बजे.
Yeah.
Check the sugar, is hypoglycemia.
Yes, I think we can conclude the session. Thank you all for patient listening. Yeah.